Hey everybody, so excited today. We're going to be going over some cardiovascular concepts and I'm ready to go ahead and get started. I think Rachel will be popping on here a little bit later, but right now me in the chat, so I will take some time for Q&A as we go along. Any questions y'all have. Just wanted to say that I'll also put on here coming up some links for y'all to check some other things that we have going on this summer coming out. Just a lot of really exciting things here at Archer. So without further ado, we'll go ahead and get started. The first topic today is going to be hyperlipidemia. So remember, that's just excess fat in the bloodstream. And here is your chart for the normal cholesterol ranges. So we can see here that total cholesterol within normal limits is going to be 200 or less, triglycerides 150 or less. The LDL, or that low density lipoprotein, which is our bad cholesterol, we want it less than 100. And then our HDL, or high density lipoprotein, we want it 40 to 60 or higher. And just remembering that this helps to cancel out the bad cholesterol. This is our good cholesterol. And 40 or above is cardioprotective for men, whereas women, we have it a little bit harder at 50 or above is when it becomes really cardioprotective for us. All right, we're going to go ahead and talk about risk factors and the types of hyperlipidemia. So this is going to be common in those middle-aged adults. And remember that we have primary, which is going to be family risk, genetic links, and regardless of what these patients do, they're going to have hyperlipidemia. Doesn't matter their lifestyle modifications they make. Of course, we still want them to make some lifestyle modifications to keep it as low as we possibly can, but they're still going to have some sort of form of hyperlipidemia. Secondary type is the one we hear about the most often. That's going to be those that have to do with lifestyle and lifestyle changes, which are always our first line for treatment options, is going to be the number one way that we can help mitigate those risk factors. So again, thinking to ourselves, is there a way that we can help to reduce the risk of heart disease in our patients? So can you all put in the chat here some things that we can encourage our patients to do to mitigate the secondary type of hyperlipidemia? Who can put on here what we can offer them to do? I'll read you some of the examples. Yep, exercise, very good, Cynthia. So keep those in. Yep, low saturated fats, diet changes, absolutely. Triglycerides are going to be really correlated to those carbs and sugars as well. People often forget about that, especially if they have diabetes to go with this. Some things that I like to think about as a clinician in clinic is, I really talk to them about barriers and what are some of the barriers that they feel like is keeping them from lifestyle changes. Like some patients might have chronic pain. So can we get them in some physical therapy to help promote that exercise? If they're smoking, are we offering them some options to help with smoking cessation or at least cutting back? So, I like to come up with ways that I can help my patients implement the changes that I'm recommending that they make versus just, having a chat with them and then it's not really feasible for them once they get home and then they feel overwhelmed. Okay, these are just a couple things that we do check on our patients. One of the things that we're doing here is checking apolipoproteins. Now, these are little vehicles that cholesterol uses to circulate around the bloodstream. Apolipoprotein A is going to correlate to the HDL level, and apolipoprotein B will be related and correlate to the LDL levels, okay? So measuring these levels will help us to determine heart disease risk later on. So I will use these as a little tool to predict when somebody has high cholesterol. Again, I'm kind of trying to weed out, is this a primary, secondary cause? What's the genetic link here? And this is going to help see if they have a genetic component. So just keep this in the back of your mind. And especially if you see a patient that's really been working hard for lifestyle changes, or maybe they're a younger patient, you're kind of like, why is their cholesterol level so high? You keep these in the back of your mind and see if they have some sort of genetic link to their cholesterol. All right, so the guidelines for screening, I want to always talk to y'all about what the guidelines are so that, we talk about the USPSTF. That is going to be one of our main resources for getting evidence-based guidelines. Remember, this is a broad organization that is constantly being peer reviewed and seeing what's best practice. So it is a reliable source. And they are recommending that we screen children ages 9 to 11, and then again at age 17 to 21. Men should get their first screening at 35. Younger, though, if they have risk of cardiovascular disease, and then women starting at age 45 or those risk of cardiovascular disease as well. If they're at lower risk, then we can repeat this every 5 years. If they're on lipid lowering medications, or maybe they have that genetic link, we're going to be checking it, a lot more frequently than every 5 years. This is really going to help out when we check these younger folks here. This is really going to help to check out and see if we can have risk mitigation, if we can run that APO A and B, if they're starting to pop up high at 10 years old. They probably haven't eaten enough fat in their diet yet to really, cause heart disease yet. So we're trying to really, if that pops up positive, I'm checking that APO A and B and just seeing what we can do to help mitigate risk down the way. Okay. All right, let's talk about here. The next thing is, how do we figure out the guidelines for when do we treat hyperlipidemia? Okay. I want y'all to save these links here. Okay. These are a couple of my favorite screening tools, okay, because the USPSTF is recommending that adults be screened with a high-risk calculator, okay, from the Framingham Heart Study. So these are both from that. And this is going to help guide our decision-making on whether or not we should recommend statin therapy. So just because their LDL is high or their triglycerides are off, using this screening tool is going to help us to determine when we need to actually recommend medication and lipid-lowering agents for our patients. So these are the calculators that I use every day at work. Using one of these, you're going to input things like the patient's age, their blood pressure number. You're going to put in things like what their HDL and their LDL numbers are, their total cholesterol. They're going to have a smoking history. They're going to have other comorbidities listed in here, such as diabetes. Then this is going to give you the proper guideline as to whether or not statin therapy is recommended for the patient. So really, it's like a tailored plan for us to share with them. So again, save these right here on your, bookmarks or whatever. Play around with these. Be familiar with these. I will pull these up and show these in patient rooms so that the patient knows exactly where they stand, risk calculation score, and it's going to actually pull the guideline for you as well. So that's really, really nice. Okay, so it's going to give you like a percentage is what it's going to give you. So let's talk about what the percentages mean. Okay, that's going to be on our next slide. So on that ACSVD risk calculator, okay, this is going to calculate a 10-year risk, and then it's also going to give us a lifetime risk scoring. Okay, and it's going to give us some guidance that we can share with our patients as well. So it's going to give you those lifestyle options for the patient. If we have 5% or less, that's going to be over a 10-year history or 10-year future, should I say. Risk is 5% or less. They're going to be at low risk. So we're not going to most likely start any medication. We're probably just going to really talk about lifestyle changes for this patient. Okay. Also, this borderline risk is 5 to 7.4%. So if this patient has some sort of comorbidity like diabetes or whatever, probably going to consider starting a statin here and around that 5.5 to 7.4 risk there. This is a really good population that if they're otherwise healthy to try to get really sold on board for those lifestyle changes so that we can have risk mitigation in the future. So a lot of patients will kind of say, oh, okay, I'm borderline here. I want to start making some changes, and that'll kind of really help put the fire up under them to make the changes that they need to do. Okay, the next risk is 7.5 to 9.9%. These patients are going to get a statin. Okay, the number that I want you to remember is 7.5%. That's that magic number. Okay, and if they get that on a 10-year calculation, that's going to be my threshold if they're otherwise healthy to start statin therapy. Okay, we're still going to want to encourage lifestyle changes. Okay, but 7.5% is the number that we're going to go with, usually a moderate intensity statin. So again, I'm always trying to give my patients the least most effective dose of medication, right? So, if they're already a smoker, I can sometimes show them, like, if we take out the smoking factor, your risk factor is going to come down. And so a lot of times this will help to keep them on the lowest, most effective dose of medication. Now, if we see that they're at high risk, which is greater than 10% over a 10-year period, these patients are going to receive a high intensity statin immediately. Okay. Now, again, we're always talking about lifestyle changes with every single group. But one caveat I'm going to talk about here and pause on is that this doesn't matter. We throw this whole thing out the window if our patient has had a history of a cardiovascular event such as an MI. We will go ahead and go straight to a high intensity statin because they have already sustained damage, and we're going to try to mitigate the risk of reoccurrence because we know that they have plaque somewhere. We're trying to keep that plaque stable, and by doing that with a high intensity statin. So again, there's always, outliers to these charts that I'm giving you. So that's why I'm giving you the overview. I'm giving you the information here, but I really need you to go back and kind of dig into this a little bit more. Okay. All right, so the good news about statins is they're pretty easy to prescribe, is because there's really only about 8 statins on the market right now. And the way that we prescribe these is the difference in dosing. That's what makes them a high, low, or moderate intensity statin, okay? So, for example, let's look right here at Lipitor. Right, so I have Lipitor listed in moderate intensity and high intensity, okay? So I might start somebody on 10 to 20 milligrams of Lipitor every day at a moderate dose for ACSVD risk calculation of 8%, okay? Maybe they don't have any cardiovascular history of events, and I'm going to give them that dose of Lipitor. Now, let's take that same person and give them diabetes or a smoking status. And we're probably going to be prescribing this at a high dose, which is 40 to 80 milligrams per day. So you can see it's the same medication, Lipitor, atorvastatin, but I'm using it in a different dosage form, and that's going to increase my intensity, okay? So does that make sense to you guys? Y'all are being awfully quiet in the chat. So can y'all tell me, for example, let's look at simvastatin. Who can put in the chat the low intensity versus the moderate intensity dosing for simvastatin, also listed as Zocor on here? Give y'all just a minute to do that. Because again, this is what's going to help us in practice when we are prescribing. That's right, low. Absolutely, Erica. So you've got it. So low intensity, it's going to be that simvastatin at that 10 milligrams per day. And then if we're going to moderate intensity, it's going to be 20 to 40 per day. Absolutely. So again, just keep this little chart handy. You can see here that depending on what statin level we're trying to go to, that's going to be the milligram dosage that we play around with here. But again, remember, if they've had some sort of cardiac event, there's only 2 high intensity statins here. You're going to give them at that higher level. Okay. All right. Very good, guys. Y'all got this. So we also have patients that can't tolerate statins, or maybe statin therapy is not the only thing that is going to work on their cholesterol because they have, other risk factors, other comorbidities. Maybe they have both a genetic and a, secondary cause of their hyperlipidemia. And so they're just kind of resistant, not doing well on the statin. So these are going to be our first line, statins are, but there are several drug classes of cholesterol medications on the market. And I just wanted to kind of briefly touch on them. So as we know, some won't be able to tolerate the statins, and so we might pick another class. So for example, we might do an add-on. So there's a fibric acid drug, okay? So if we're treating someone with high triglycerides, we might look at adding on, one of those, okay, in addition to their statin. Also, if somebody's had multiple cardiovascular events and we cannot get their LDL to goal, which we're going to talk about goals here in a minute, their goal for their LDL is going to be lower than that chart I shared with you a minute ago. It's going to be 70 or less for like diabetes and things. If we can't get them to goal, we might look at giving them some sort of, injectable PCSK9, excuse me, giving them that. So there's multiple different medications. Again, you don't have to memorize all of these. The boards don't test super heavily on them, but when you're in practice, I want to make this applicable to you and just let you know that there are other things on the market that you can use, okay? So let's talk about goals for just a moment. So there's a few things. First of all, the number 70, I want you to commit that to memory right now, okay? If you get nothing else out of this lecture, the number 7.5% and the number 70 are two things that I want you to remember. So if anybody has had a cardiovascular event or they have diabetes, something that's going to make them 3 times higher just for having that disease process of a cardiovascular event, we are going to use 70 or less for their LDL of their goal. Okay, so for example, you know how on the first slide we talked about LDL 100 or less? That chart was mainly for otherwise healthy individuals. But if they have some sort of pre-existing comorbidity like diabetes or a history of a MI, something like that, their new number goal for LDL, remember the bad cholesterol, is going to be 70 or less, okay? Because these are all people are already at risk for developing heart disease, okay? So if you have any questions about that, put that in the chat. We'll go back over it a little bit here shortly, but I want you to remember those two numbers, okay, for hyperlipidemia. Okay, now let's talk about statin side effects, okay? So side effects of statins, one of the rarer ones, but it can be serious, is rhabdomyolysis, okay? This is going to be something we want to be aware of. We want to just let our patients know some signs and symptoms to look out for. Again, this is very rare, but it's something that we don't want to miss. So this is going to be caused by a breakdown of muscle tissue, and this is constituted as a medical emergency. Some of the presenting signs that you might see is like severe muscle pain. Now, I'm not talking about a little body aches, okay? I'm talking about severe muscle pain. I'm talking about dark urine. You think about those muscle fibers breaking down, they're going to have a lot of pain, okay? This is going to warrant a further workup in the ER. We're not going to sit around on this. We're not going to waste any time. If that patient calls in complaining of any of these type of symptoms, they're going to the ER. They're not wasting their time coming to my office. Another thing that we need to be aware of, again, very rare, but it is always a risk, is drug-induced hepatitis. So you are going to want to draw a CMP, or comprehensive metabolic panel, and check liver enzymes about 30 to 60 days after initiating a statin therapy. Checking in with a follow-up with any new medication is going to be important so that we can catch any complications or side effects early. My personal rule is if you get a new medication by me today, 30 to 45 days out, you're going to come back. You're going to get lab work if it's indicated. Again, if I've started you on a statin, it's going to be a CMP. And you are going to have a check-in with me, see how you're doing, make sure that you've been able to be compliant with the medication. You know, if they come in and they say it made me sick as a dog, they're probably not being compliant with their medication, right? So I want to give them an opportunity to just, ask them, how's your medication working? Did you have any concerns? Maybe the cost, we don't always realize the cost when we are prescribing things. I try to be mindful of that, but you just don't always know until the patient picks it up and their insurance has, either gone through or not. And so I like to just talk to them about, how's it working? You feel like you need to go up or down on the dosage, or, whatever it be. So just really, again, starting slow and low on these dosages of medications, and then working your way up to higher doses, I found really helps to decrease, side effects and things with the patients, helps to keep them more compliant on their medication regimen. So just paying attention to that. And again, getting those labs when they're indicated. All right. So, talking about your role as a nurse practitioner, we have our foundational knowledge of coronary artery disease, and we're going to think about what we need to assess in our patients who are at risk for this condition. So, obviously, anyone who has elevated lipid panels could be, storing this as plaque in their vessels. Most likely they are. And so, we need to be mindful of this, and we need to get a good health history and physical exam. Do they have a bruit, whatever it be. You might see those little melanthas on the eyelids, those little yellow like waxy areas on their eyelids. You might see that their blood pressure is high, maybe also have other comorbidities such as obesity, diabetes. So these are going to be some of your physical assessments and your objective data that you can collect that kind of might tip you off that someone's having hyperlipidemia. Of course, our lab work is going to help confirm this. So what all things that you all might want to think about with your physical exam? Does anybody have any other ideas here? Y'all can put that in the chat of some physical exam and other lab values that y'all might want to draw if you are trying to make the diagnosis of hyperlipidemia. So I'll give you just a minute to think about that. And again, there's some hints there for you on the slide. So think about what you might see. Kind of touched on some of those things. Okay. Yep, absolutely. The whole lipid panel. Yep. Liver enzymes. Absolutely. Before starting your statin. You've got it. Very good. Erica is ready. Okay. All right, so I'm just going to pause here. I'm going to give y'all just a moment to finish up that question I just asked. I'm here in the chat now. I've got it opened, so any questions y'all want me to clarify, and y'all can put that there in the chat, and I'll come back to you in just a minute. In the interim, you all can think about this question. Miss Hadley, a 47-year-old female, comes in to see the nurse practitioner for a follow-up 1 month after starting atorvastatin 40 milligrams. I'd give you bonus points if you could tell me if that was low or high dose intensity. She complains of new onset muscle cramps and dark urine today. Which lab tests must be ordered along with the CMP? Okay. So y'all think about that. What concern might we have for this patient, and what lab tests are we going to order? Again, I told you, don't waste time in the office. But if you were going to check it, what would it be? So y'all can put that in the chats. Y'all can put your answers in the chats for your physical exam findings, questions you might have, and then also the answer to this question. So is it going to be A, creatinine kinase, B, antinuclear antibody or an ANA test, C, a complete blood cell count, or D, troponin? Y'all got this. Very good. Absolutely. Anybody else want to take a guess before I give y'all the answer? That's right, Cynthia. They're going to the ER. They're not hanging around our office, are they? That's right. Y'all got this. Y'all are ready. A is correct. Absolutely. Creatinine kinase. That's the one that's going to show that they have some sort of muscle breakdown, right? Anything creatinine kinase level that's over 5 times the upper limit of normal constitutes that emergency room visit. If we're not sure, we're going to still send them to the ER. And remember, this is showing muscle breakdown, which could be indicative of rhabdomyolysis. So y'all got this. Very good. Y'all were paying attention really well. So great job, guys. Absolutely. All right, I'm going to give y'all another question here. So this is Mr. Kendrick. He's a 72-year-old male, and he has a history of hyperlipidemia. He comes into your primary care clinic today for his follow-up visit. The nurse practitioner auscultates a bruit over his left carotid artery. What initial imaging is going to be used to verify plaque in his carotids? So you heard a bruit on physical exam. So now what are you going to do? We're going to document that, but we also probably need to get some imaging on him. So which imaging test is going to show the plaque in the carotids best? So we have X-ray. B is going to be a CT scan. C is going to be ultrasound. And D is an MRI. So what do you all think is going to be your first line? I'll take a guess. Give you just a minute to put it in the chat. Absolutely, you guys got this. That's an ultrasound. That's right. So that, again, the stem of the question is basically talking to us about, this is an initial finding of a bruit, and the stem of the question is wanting to know what your initial imaging is going to be. Okay, so again, reading your question, y'all have got that. Initial imaging is going to be ultrasound. So if this patient has atherosclerosis of the carotids, he's going to be going somewhere else for further workup and seeing how much, occlusion he has and everything. Cardiology may go on to produce high quality CT or MRI imaging of vessels, and that's great. But in primary care, we are going to start this with an ultrasound and see how much blockage he has in those carotids. So very good, you guys, y'all got that. All right. Okay, we have another question for y'all. A 54-year-old male comes into the clinic for his annual wellness visit and lab works, okay? His cholesterol panel is as follows, all right? Total cholesterol 270, triglycerides at 692, HDL is going to be 54, and LDL is 143. So I want y'all to think about what you're doing here with your lipid panel. Doesn't say he has any other comorbidities, right? The nurse practitioner describes to prescribe fenofibrate to reduce the triglyceride level and prevention of the development of this condition. So I want y'all to think about what condition we're trying to mitigate here. Which number on there is going to be the, most concerning, let's say. It's going to be jaundice, B, pancreatitis, C, rhabdomyolysis, or D, drug-induced hepatitis. So which one here is going to be our most concerning? Absolutely, you guys. Very good. That's going to be pancreatitis. That's right. You all know they're going to be at a high risk of pancreatitis. Anybody who has triglycerides up over those 500 levels, absolutely. So we're going to start the fenofibrate. We are going to want them to avoid alcohol. We're going to want them to watch their carbs and sugars. And the other answers are going to be complications to watch for in patients on statin therapy. So very good. Y'all got it. We need to also warn him of the signs and symptoms of pancreatitis. That wasn't in the rationale, but that would be something that I would want to let my patient know. If you're starting to have, a lot of symptoms like nausea and vomiting or yellowing of your skin, you probably need to go one down to the ER. Okay, we're going to take just a breath here. And before we get into our next topic of hypertension, I just wanted to let you all know a few of the exciting things that we have coming up here at Archer over the summer. Our team has been working really hard, and we have another live 3-day review coming up. Again, this price is still the same, $50 for 3 days. We had a really great time and turnout last review. If you all missed this and you're coming up to get ready to test here in the next few months, I can highly recommend and stress this enough. Our new dates for this are going to be July 19th through 21st. I would encourage all of y'all to come. And yes, it is going to be essentially the same. Morgan, are you here? If you want to pipe in and tell us a little bit more about the review, you are welcome to do that. We are going to, mainly go over all those topics, all the body systems, go over everything. Again, if you are even in your nurse practitioner program, getting towards the end, this is something that I would want to encourage. In addition, we always have these free weekly webinars. Check our schedule. We have a lot of good stuff coming up. And then the Q Bank, we still have a free 30-day trial out there for you guys. So this is something I would really take advantage of. Summertime, hopefully things are, I don't want to say slow for you because I've been to NP school. Summer is very busy, but this is something that you might want to think about on your break between, around 4th of July, or your break, those first week or so of August that y'all have between semesters. This is something that you want to think about and really take advantage of. So, again, can't recommend these, a lot of free things that you can take advantage of as well. So, Morgan, I didn't know if you had anything to add. I don't know if you're here today when they want to know if this is going to be exactly the same as the last review. Okay, she may not be available right now. Okay. Oh, there she is. Okay, going to be some updates here and there, but overall this is going to be the same content. Okay, yes. And I think some of our topics, like, we've kind of moved them around too. So, but we would love to see each and every one of y'all on the 3-day live. Okay, so there's your QR codes. If you have any questions, we've also put the email address here for you for specifics. So we just love to connect with all of y'all because, of course, we love all of our students. All right, so let's go ahead and we're going to move right into hypertension. And this is another topic that you are going to see every single day in primary care. This is something that you need to know forwards and backwards. And again, I'm hitting the highlights here today. So this is something, it's a huge topic. And, it's just something that you definitely want to be aware of because it's very important. So let's go ahead and talk about cardiovascular disease worldwide. This is a silent killer. It often goes unnoticed for years and years, and then the damage is already done. So, that's why we really recommend these, blood pressure screenings for all of our patients, just kind of really trending those numbers and, really getting the word out there of what constitutes as high blood pressure, what constitutes as low blood pressure. So always just using those opportunities to talk to my patients and their family members and, keeping a watch over their blood pressures, especially if they're on a lot of different medications, something that they need to really be aware of. All right. So this is just something that I want to draw your attention to on this chart. Okay. The American Heart Association. This is going to be where we're kind of headed. The guidelines have gotten a little bit stricter. Normal is going to be, as you can see here, 120/80 or less is going to be normal blood pressure. Okay, when we start getting above there, we're going to go start moving into this yellow category, also known as elevated here. And then we have different stages of hypertension now. So we have stage 1 hypertension, 130/139/80/90. Stage 2 hypertension, getting a little bit, sicker, if you will, 140/90 or greater. And then we also have a hypertensive crisis. I tell my patients, 180, and even though this isn't the guideline, but I tell them if it's 180 or, around 100 to 110 on the bottom, especially if it's 120 or above, they need to go onto the ER. And, have this looked at, because this can become a crisis very quickly for them. So that is something that, again, they're not going to be hanging around my office with blood pressure readings that high. All right. The other guideline that we have to follow is the Joint National Commission, or JNC 8. These are a little bit different as well in regards to the categorization of the blood pressure readings. We really are trying to move everybody to American Heart, but this is just something to be aware of. The exams will not try to confuse you, but the main thing is that I do like this because it does talk about tighter control amongst patient populations with diabetes, CKD, or younger patients. So, really this one kind of cuts off at that 140/90. And then for everybody else who's like older, 150/90. So, we're always concerned about falls in our elderly and everything. And so this is just another like guideline that you can utilize and take a look at and keep in your back pocket for those, again, outliers. All right, so how are we going to diagnose our hypertension? Okay, so first of all, most everybody is going to be nervous and stressed when they come into our office. So I will take a blood pressure reading at the office, but I don't put all of my stock in that by any means. I want them, if I get a high blood pressure at the office, usually I'll check it myself, again, like towards the end of the appointment, after we've already chatted and maybe they're a little less stressed and they've had some time to sit and relax. I'll also ask them to take some blood pressure readings at home. So I'll ask them to go home and take it at a time when they're not stressed. They didn't just walk in the door from a really long, stressful day at work. They're taking it for about 2 to 4 weeks, when they have sat down with their legs uncrossed for at least 5 minutes. And then some people just have white coat syndrome. So they're, half of these people are going to come back and be like, yeah, my blood pressure is normal at home. It's only when I come here. Okay, they may have some white coat syndrome going on. And then also there is something called masked hypertension. So in their office, they're within normal limits, blood pressure, but that can be high at home, running high at home. So that one's not as common, but I have had a couple patients where they have come in and kind of tattled on themselves as like, my blood pressure is running really high at home and it's good today. And, we'll kind of look over those readings. So again, I really like to track and trend my blood pressure numbers before I go and start throwing medications at patients. Okay. So just something to be aware of here. All right, so first of all, primary or secondary, okay, we have some different causes for why their blood pressure could be going high, right? So it could be, just genetics. It could be environmental. It could be, maybe they have a lot of stress at work, something like that. They could also have behavioral issues, like maybe they are smoking or maybe their diet is really high in salt. Secondary causes is going to be, of course, anything going on with their kidneys or cardiovascular system. It could also be, endocrine. It could be some of their other medications. So a lot of different things can kind of lead to the development of high blood pressure readings or hypertension in general. And then, of course, we have hypertensive emergencies. So if they, don't normally have high blood pressure, or maybe they run a little bit high, but then all of a sudden their blood pressure is really sky high, that is going to be, again, an emergency room workup. Okay. All right. So it's important for these patients to be taking their blood pressure at home. So I really just try to make sure everybody has a cuff, if they're even borderline, so that they can be watching it at home. All right. Let's talk about organ damage. So we talked about how this is the silent killer. We've talked about how this will go on for years and patients don't even realize or know what kind of damage has been done. But these are just some things that we need to be mindful of, because a lot of times we're not catching this hypertension until damage has been done. Okay, so I'm not going to read this entire slide to y'all, but this is something that I want you to pay attention to. Of course, on our heart, on our cardiac exam, we will we might hear a little something, and they will get left ventricular hypertrophy. We can confirm that with an EKG. And the most common cause of LVH is going to be long-tracked undiagnosed hypertension. Okay. In addition, if it's really high and really scary, aortic dissection, hopefully we've caught that and sent that to the ER in time. Some sort of ripping sensation in their abdomen that needs further workup immediately. We can have eye changes. We can have changes in our brain with like small vessel disease, vascular dementia, stroke, puts us more increase for that. And then also thinking about our kidneys, because remember, our kidneys and our hearts hold hands. And so, we don't want them to end up in renal failure all because we didn't watch over their blood pressure. So just some things to be very mindful of, something that we can, try to catch and mitigate these risks. So, all right. The tricky thing we've already talked about is going to be because this hypertension will often go unnoticed. And so the patient's not going to give us any type of complaint unless we've caught it early or they're having some sort of massive issue. Maybe they are having horrible headaches, especially in the mornings, or maybe they are having a nosebleeds, something like that. But a lot of times these are just kind of caught, more transient in these office visits. They may even be seeing you for another issue. So, if you know that blood pressure is elevated, you're going to want to inquire about important details in their history. So, a lot of times patients will come in, and once you start kind of talking to them and digging around, they're there for a cough today, let's just say, but really and truly they're also having ankle swelling, or they've been having palpitations. That's going to start me down more of a CHF type workup, right? So thinking about, signs of target organ failure, thinking about family history, if their mom and their grandma and their uncle all have it, there's a better chance that they might have it too, right? So these are all things that we need to kind of be aware of. All right, I want y'all to think about your physical exams for hypertension. So let's say that you have a patient that comes in and they haven't been to the doctor in a while, like a lot of people have it with COVID. And I want y'all can use the slide for some help too. I want y'all to think about, when your exam, I like to think of us as detectives sometimes. I want you to think about, you're doing your exam, what are some things that you really want to physically assess during your assessment time? So y'all can go ahead and put that in the chat. I want you to think about what we need to assess, because remember, this could be silent. They just had an elevated blood pressure reading today. They haven't been to the doctor in, let's say 4 years. What are some things that you might assess to help either rule in or rule out your diagnosis? So who can put some things in the chat for me? Give y'all just a minute to think about that. Okay, so Mr. Jones is here today for his checkup. And what y'all gonna do? That's right, eyes for cotton wool spots, the carotids for JBD, also for Brewy, as we talked about just a few minutes ago, because we're thinking about cardiovascular stuff. Very good, Erica. Who else wants to put something in the chat? Don't be shy. I promise I'll steer you in the right direction so you leave out of here in a good spot. What about thyroid enlargement or peripheral pulses? One side feels different than the other. Maybe one side's bounding and one side's a little bit like weaker. What about S4 heart sound? Right, that could be tip off to that LVH, where that left ventricle really like stretches out from where that blood has hit it over and over again, and it's become stretched. Their apical pulse might even be displaced. So very good, guys. Y'all got this. All right, Some ocular findings, just like Erica alluded to. These are some things that you might see on your retinal exam. Now, we are not eye care providers. So if our patient, I encourage all of my patients to get an annual exam on their eyes, of course, but this is something that, we can be taking a quick little peek, doing a little assessment on, and we might see some of these findings. So cotton wool spots, AV nicking, papilledema, copper wire arterioles where they've gotten larger and grown extra vessels. So these are some things that, it's going to warrant a further workup from ophthalmology, okay? So just some findings that you might see. All right. Your workup is going to be dependent on the evidence of the target organ damage, the suspected etiology, and the cardiovascular risk factors. So I want you to think about your basic labs. You're going to get your 12-lead EKG. Also, if we feel like the patient has some sort of thing going on with their kidneys or, something like a tumor or something, we're going to go ahead and order a renal ultrasound. And then we can also get like an echo if you feel like the patient has LVH on their EKG and they're starting to head towards, some little bit of heart failure. Maybe they do have that cough or difficulty lying flat or swelling in their legs and feet. And then we also might get a CTA of the chest if we suspect some sort of issues with the aorta. Okay. In addition, sleep apnea can cause hypertension. They kind of go hand in hand as well. And so that's something that we might consider as well. Okay. So your workup is really going to be dependent on what you feel like could also be going on with your patient. All right. So our first line therapy, once our patient's been diagnosed and properly worked up, we're going to start with lifestyle changes. So who can put on here? We're always educators, putting on your educator hat now. What are you going to talk about with your patients for lifestyle changes for hypertension? Do y'all want to think about what lifestyle modification, which is our first line therapy, especially if it's just kind of in that borderline stage 1 area, we're going to really try to increase exercise. We're going to increase what else? What are some things that we can have our patients do? That's right, absolutely. So DASH, low salt diet, exercise, stop smoking, limit alcohol. Absolutely, guys, y'all have got this. Increased physical sitting or activity and less sitting. Yep. Weight management, heart healthy diet. Absolutely. So very good. Y'all have got this. Y'all know what to educate your patients on. But this really is, again, we talked about doing the least most effective dose of medication. So this is something that we can help, if they're going to go on blood pressure medicine, eventually we can be giving them a lower dose because they're already implemented these healthier lifestyle changes. All right, let's talk about medication. So the decision for pharmacologic management is just really going to depend not only on the grade of blood pressure, but also on risk factors. So do they have cardiovascular disease? Do they have diabetes? Do they have CKD? Their 10-year calculated risk is going to be 10% or higher, or age 65 or less. These can be calculated using that calculator, but I do want you to remember, regardless of their stage of blood pressure, okay, even if it's just stage 1 and their ACSVD risk calculation is 10% or greater, they are going to start on blood pressure medication. One way to remember this is going to be hypertension. So that risk calculator of 10% or greater, you know how we talked about 7.5 or greater for statin therapy? This one's going to be 10 for hypertension. Okay, some drug classes that we want to talk about here. Our first line is going to be ACE inhibitors. Okay, that's angiotensin converting enzyme inhibitors. These in Peril. Okay. Also, we can talk about things like aldactone in certain patients, and loop diuretics are not usually going to be used as well. But sometimes you will see your patients on these, but these are going to be your main classes here that I've listed. So the ACE inhibitors, the ARBs, the calcium channel blockers, beta blockers, and thiazide diuretics. Okay. The next one, the ARBs, is going to be the ending in sartan. So remember, the ACEs are going to be ending in pril, and the ARBs will end in sartan, okay? And the ARBs are going to work by blocking those receptors. And then it's also really important to remember that some of our contraindications, so who can put in here what class or the reasoning for not giving these medications to this population. So let's talk about absolute contraindications to ACEs and ARBs. So who can put in there in the chat some of the contraindications and the absolute and relative contraindications for ACEs and ARBs? So who can list that? So, and I've got it on here for y'all too. That's right, pregnancy, absolutely. Those who have gotten angioedema, that's swelling of the face. And so this is something that we are not going to prescribe these two medications for. Some other contraindications that you might at least want to think about are things like aortic stenosis, renal stenosis, elevated creatinine, and hypovolemia. Again, thinking about how these medications work, we might want to be cautious with those drug classes, okay? And who can tell me the most common side effect from ACE inhibitors? Remember, it's not harmful, but it's annoying. But what is the number one thing that we want to talk to our patients about? Absolutely, Madison, you got it. Yep, Erica's got it too. That's right. Yep, Mandeep's got it too. That's right. That dry cough, absolutely. Patients will find this so annoying. So a lot of times we're going to end up changing them to an ARB because that cough is so annoying. It's keeping them up at night. And there's really no reason for it. So we can change their medication regimen, okay? Let's move on now down here to beta blockers. These are gonna work by blocking the release of that stress hormone, adrenaline, and lower our heart rate and blood pressure. You know, these are gonna end in LOL, so things like metoprolol. This is gonna be used very commonly. It can help with rate control as well of their heart if they need that. And we actually do see these used in pregnancy. And I want y'all to think about this. Who can tell me the go-tos for pregnancy, for hypertension in pregnancy? Can anybody tell me the go-to medications for hypertension in pregnancy? Y'all can put that in the chat. All right, calcium channel blockers. These are going to inhibit the movement of calcium into those cardiac channels, and they can be broken down into two subcategories. And these are going to be really have the side effects of things like ankle swelling and headaches. And this is something that we just kind of want to be aware of with this drug class, okay? We also want to avoid these in patients with heart failure because I want you to think about ankle swelling is one of the common side effects. And so we want to really shy away from that to not cause them more edema in their legs and feet. Moving on here, thiazide diuretics. These are going to be blocking the action of those sodium chloride pumps in the kidneys, increase the release of sodium, potassium, and water into the urine rather than back into the bloodstream. Remember, the thiazide diuretics do cause that diuretic effect. And so we really want to pay attention to not using these like in our diabetic patients, those with gout, anything that's going to dehydrate those patients. Who can tell me a drug class that's good for osteoporosis? Okay, osteoporosis. There's a drug class that's out of these 5 that I've listed here that's good for patients with osteoporosis. That's right, Madison, thiazide diuretics, absolutely. So they do help with bones, and they're good for patients with osteoporosis. And y'all have got it with the patient safety for hypertensive medications in pregnancy. I like to think about this as LMN, just like the alphabet. We have labetalol, methyl-dopa, and nifedipine. Absolutely. Y'all have already listed all of those. And yep, you've got that beta blockers. Absolutely, that's in there. So very good. All right. There's also another little note here about thiazide diuretics that I want to give y'all before we wrap it up. And there could be a cross sensitivity with sulfa drugs. So also with loop diuretics as well. So thinking about these 2 drug classes could be not the best choice for patients with sulfa allergies. So just a little note there, a little side note. All right. Let's see here. Oh, we've already talked about that. Okay, so the JNC8 gives you some lists for options of patients, some drug classes to give with the blood pressure. So thinking about, if they have diabetes and CKD, ACE or ARBs, they're younger patients. And then depending on, they also have some ethnicities, things here that work better for specifically like African American population. So just be mindful of that, again, if you're going to be using the JNC8 guidelines. Okay. All right. I want you all to think about the red lines with hypertension. Okay. When do we need to send these patients to cardiology? Okay. So remember, you are going to think about the things that the patients would kill them first, right? So, pediatric patients, these little ones need to be looked at by cardiology. Hypertension that's just not getting better with medications. So, like, for example, if they're on multiple medications, like after we've given them maybe, 3 medications, they're probably going to be going to cardiology because why is it so resistant to the, medication? Also, pregnancy patients, we need to have them managed with their OBGYN, and then also any cardiac conditions that could complicate treatment. So these are some things that you need to be, mindful of. These patients, they can get very sick very fast. These blood pressures can shoot up very high to a scary, scary level quickly. So this is something that I want y'all to be aware of. All right. This is just the next thing I'm going to just talk to y'all about for 1 minute here before we wrap it up with y'all is isolated systolic hypertension. This can be common in older adults due to the loss of elasticity of the arteries. And first line treatment will still be your lifestyle modification, and then the low dose thiazides, diuretics, or calcium channel blockers. Okay, ACE and ARBs aren't usually the first choice for this particular condition. So this is just something to be mindful of if you see this in your older adults, and think about those main things that go with hypertension. You're going to do fine on your boards. Okay. I have a question for wrap up for y'all. Y'all have done a great job today staying engaged and interactive. Y'all are going to do a wonderful job on your boards, those who are coming up on it. I know because y'all have answered all of the questions today very well, like a pro. And let's just finish this up to make sure that you got the number one take home point away for hypertension in pregnancy. Okay. So Mrs. Jones is a 35-year-old female and 6 weeks pregnant, is due to see her OBGYN next week. The nurse practitioner notes on her medication record she's taken lisinopril 10 milligrams daily. Which hypertension medication could the nurse practitioner consider to be a safer alternative? This is a select all that apply. So y'all can pick out which ones. A is going to be labetalol, B will be methyl-dopa, C will be nifedipine, and D will be losartan. So that's right. Y'all got it. Absolutely. Absolutely. A, B, and C, just like we talked about. L, M, N, like the alphabet, right? Labetalol, methyl-dopa, and nifedipine. These are all going to be safe for that patient in pregnancy. And of course, we already know she's going to be co-managed by OBGYN. In fact, that's who's going to be probably titrating her medication dosage. But today she's here, and we don't want her to be pregnant one day any longer without the appropriate medication, right? So we're going to avoid those classes like ACEs, ARBs, statins, and DMARDs. We are going to really pay attention to LMN. So those are just some 3 medications you can keep in your back pocket, knowing that those are safe for pregnancy. All right, guys, we literally have 2 minutes left. I really appreciate all of y'all hanging out with us today. I'm going to see y'all again soon. We have some other webinars coming up over the next few weeks, so check those out. And if there's any other questions, I'll hang around for just a minute to clarify anything. And I hope that this has been useful and informational for you today. Okay, so somebody just asked if we're going to be doing a dermatology soon, and the answer is yes. I'm going to give y'all the date for dermatology. I'll give y'all like a little hint here at some of these webinars that are coming up. So let me just get over there to that. Let's see here. Go to it. So dermatology is going to be in just shortly. Let's see here. July 1st at 10 a.m. is when our dermatology lecture is going to be. Let's see. Morgan, are you still with us?
Yes, I'm here.
Okay, so somebody is asking about access for the handouts for previous recorded webinars and a handout of this webinar. Where can they get that?
Yeah, if you guys want to give us a shout over at nurse practitioner at archerreview.com, we can help you out with those.
And I'll put that in the chat for y'all.
And with that being said, if you guys want to make sure, here, let me turn my camera on so you can see my face. If you want to make sure that you're getting all of the handouts for all of the webinars, not just like, oh, this webinar here, this webinar there. If you want every single system and you want to make sure you have all the notes, you can go ahead and just sign up for our on-demand video package, or go ahead and do the combos so you get that question bank. And that is going to include a handout linked right to that video so that you go ahead and get everything. We're getting those uploaded. I believe the technical team is doing it as we speak, that it'll be up very soon. We're making sure we're getting all of them for you guys. So if you already signed up for the combo and you've got it, keep an eye on your student dashboard. They're all going to be right there. If you don't see what you're looking for, again, just shoot us an email. Brittany went ahead and put that in the chat for you, and we'll make sure you get what you need.
Yeah. Okay. All right. So it sounds like we answered your question, Mandeep. Yeah, absolutely. And, also something I didn't even mention today, Morgan, is that tutoring. We have just launched tutoring the last, maybe 2 weeks for FNP. Thank you, Mandeep. I enjoy doing reviews with you guys. And the tutoring is you can sign up with any of us, the tutors that were in the live review we just did, and the ones that you see on the webinar all the time. And we can spend, some time together digging into specific topics that you would like to do, and really just make this really student-led and guided time. So I encourage you all, if there's, something that you are getting ready to test on or you're struggling with, I would have loved to have had a tutor on some of these things to really just nail down those concepts. So Morgan just put that in the link for y'all. That's something I didn't even mention today, but yeah. And we could do a time on dermatology, right? And you could have that before July 1st. So just some ideas for y'all. We just want to be a resource for you all. All right. Any other questions before we hang it up for the day? All right. Okay. So Mandeep says, comment here, a couple of tutoring sessions in the combo pack. Okay. Some thoughts. Hey, we're open to suggestions. Absolutely. All right, you're so welcome. Hey, I'll see all of y'all next week, and y'all can hop on with some of the other instructors throughout the weeks as we go along, and I hope to see all of y'all there. Y'all take care.